So as we continue with our colorectal series, I'll be taking you through a research that we conducted at KNH on factors affecting the outcomes of intussusception. My moderator was Dr. Francis Osawa. This is my outline. So intussusception basically is a condition where bowel loops invaginates into a distal segment and involving either the small or large bowel or either both of them. So it's the most common abdominal emergency in infancy and early childhood, the ages of 1 year, and can occur in children up to 5 years. Late presentation is quite common in Africa, and it contributes to fluid losses, shock, bowel ischemia, necrosis, sepsis, and even multi-organ dysfunction on the severe end of it. So these complications usually increase the need for critical care in patients with a high risk of clinical deterioration. So a surveillance study was carried out in 7 sub-Saharan African countries, including Kenya, and they noted the mortality was as high as 13%. The risk of developing post-op complications was quite similar in several East African countries, 36% in Ethiopia, 32.1% in Tanzania, and 41% in Kenya. Surgical site infections were the most common being reported in all this literature. So the mean duration of hospital stay in most African literature is at 9.2 days, and it is portrayed to be longer in patients who develop post-op complications. So my study aim was to evaluate both patient and surgery-related factors that can affect the outcomes of childhood intussusception. We carried this out at Kenyatta National Hospital. It was a retrospective descriptive study. Medical records of patients below 15 years with radiological or surgical diagnosed intussusception were retrieved between January 2017 and December 2022, a period of 8 years. So variables that we collected included demographics such as age, sex, weight, duration of symptoms, laboratory parameters like hemoglobin, mean corpuscular volume, serum albumin, serum lactate, and operative findings like the surgical duration, surgical intervention done. Post-op complications were graded as per the Clavian-Dindo classification system. The other outcome measures that we also analyzed were length of ICU stay, length of hospital stay, and mortality. We carried out descriptive statistics to analyze both continuous and categorical variables, carried out logistic regression, and those factors which were considered statistically significant were then included in a stepwise logistic regression to see independency of association. So the primary outcome measures were post-op complications, hospital stay, and mortality rate. And then we carried out associative analysis. Our ROCEIV curves were used to evaluate the laboratory parameters to see a cutoff value on which one was associated with surgical outcomes. So our results, we had a total of 288 cases over a duration of 8 years, male to female ratio of 1.5:1, median age at diagnosis was 6.5 months, and the median duration of symptoms was 3 days, with a range of up to 21 days. So in our cases, we had 12 cases constituting 4.3%, which had spontaneous reduction. So these were excluded from the statistical analysis. Of the patients who underwent surgical intervention, a majority of them had manual reduction, followed by 19.2% who had resection and stroma fashion. Lastly, patients who had resection and anastomosis. Our overall resection rate is at 30%, which is in keeping with most literature in African settings. Of the patients who underwent surgery, those requiring resection had a significantly long duration of symptoms compared to those who had just manual reduction after carrying and Whitney test. So those who underwent surgical intervention, up to 27.8% had post-op complication, excluding death. Commonest complication was wound sepsis. and a majority of patients had Clavien-Dindo classification, minor complications. Those who were admitted in ICU, they had a median duration of stay of 4 days. Median duration of hospital stay was up to 5 days. We had a mortality rate of 10%, as you can see in my introduction. In sub-Saharan Africa, it's quite similar. Mortality rate 13%. So we carried out a statistical analysis further to see at which cut-off patients with anemia were likely to have post-op complications, and the cutoff value on the ROC curve was at 10.2 grams per deciliter. Up to 90% of patients who had anemia actually had low mean corpuscular volumes for E. Significant association between serum lactate values and bowel gangrene, with an ROC curve giving us a cutoff of 2.3 millimoles per liter. In terms of the other lab parameters, we also did ROC curve values for preoperative albumin to see association with post-op complications. And we had a cutoff of 32 grams per liter for Clavien-Dindo grade 2 complications, and for grade 3 and 4, the cutoff value was 30 grams per liter. So we could see that pre-op albumin is actually an independent risk factor for post-op complications. Other variables that we analyzed were age below 1 year, female sex, and prolonged duration of symptoms, also noted to be statistically significant predictors of mortality. Up to 60% of patients who underwent stoma fashioning actually developed post-op complications, majority of which were grade 1 and 2, such as electrolyte imbalances and parastomal skin excoriation. But some actually had major complications like stomal prolapse and even burst abdomen. Of those who underwent bowel resection, they actually had a longer duration of hospital stay, especially those who had stomas fashioned. They take a longer period to be stabilized for the complications that they developed, and subsequently underwent reversal. So prolonged operative time was also noted to be significantly associated with poor outcomes, especially wound sepsis. So in my discussion, I'd like to take you through various literature that reports similar findings. So I grouped the factors which were affecting outcome into two: patient-related factors and surgery-related factors. Patient-related factors, as I've previously mentioned, and the surgery-related factors have also done the same. So the literature that concurs with these findings, Karapenia in South Africa noted that prolonged duration of symptoms were mostly due to socioeconomic, infrastructure, and even health management deficiencies were associated with poor outcomes. Chalia in Tanzania, Eaja in Nigeria also noted age to be a predictor of mortality, especially those below 12 months of age. A retrospective study carried out in Japan by Lee Mamoto noted that patients who had emergency laparotomy, irrespective of the indication of laparotomy, if they had pre-op low albumins, they were highly likely to develop complications post-op. Serum lactate also noted to be associated with in-hospital mortality, SSIs, and even longer duration of hospital stay. Long operative hours were also noted to be associated with complications, especially in bowel surgery by Short-Het et al. Bowel resection is common in patients with prolonged duration of symptoms and is associated with poor outcomes. Stoma-related complications, Vogel et al. Had described quite a number, mainly Clavien-Dindo grade 3, in children with various indications of stoma fashioning. So in my conclusion, I'd like us to take home that intussusception is not a benign condition. On the contrary, it's associated with significant morbidity and mortality. Patient as well as surgery-related factors may actually assist in decision-making and improvement in referral system so that we pick these cases early will save us the varied amount of morbidities and even mortality. And further studies may actually be validated to see if there's an associative finding on why these patients actually have low mean corpuscular volumes. Thank you. These are my references. Thank you.